Dr. Margrethe Horlyck-Romanovsky discusses intra-ethnic diabetes disparities and how to optimize diabetes risk assessments for diverse populations. She also talks about how immigrant status, ethnicity, and race can influence diabetes risk in populations of African descent.
Podcasting from Dallas, Texas, I am Shireen, and this is the Yumlish podcast. Yumlish is working to empower you to take charge of your health through diet and exercise and reduce the risk of chronic conditions like type 2 diabetes and heart disease. We hope to share a unique perspective and a culturally relevant approach to managing these chronic conditions with you each week.
Dr. Horlyck-Romanovsky is a public health nutrition professional committed to addressing intra-ethnic health disparities among populations of African descent. Her mixed methods, research examining intra-ethnic risk profile research in New York City, compares risk factors, health behaviors, and disease profiles of African Americans, African-born Blacks, and Afro-Caribbeans. Welcome, Dr. Horlyck-Romanovsky.
Thank you so much for having me. It's a great pleasure.
An absolute pleasure having you on. I want to kick things off by asking you, how did you get involved in research exploring the intersection of diabetes, race, ethnicity, and acculturation?
Right. So how did I end up working on this? So after a career in nutrition education implementation, I shifted gears and went back to graduate school, essentially because I was largely frustrated by health disparities and sort of the lack of progress in addressing these issues. And while doing my doctorate, I started teaching at Brooklyn College. And Brooklyn College is part of the City University of New York system, which is one of the most diverse university systems in the country. And Brooklyn College is situated in Brooklyn and surrounded by many immigrant and U.S. communities, including sizable South Asian, Orthodox Jewish, Russian, Turkish communities, and a very large Black Caribbean enclave. And that was really where all this work started. I had sent my community nutrition students out into the world to conduct community assessment. And one of the questions they had to address was, what health concerns does the community members rank the highest? And what do we know about the issue from contemporary evidence? And as nutrition and public health professionals, how might we help address this? And the group is assigned to speak with the Black Caribbean communities, largely Jamaican, Trinidadians, Tobagoan, Haitian, people from Guyana, Barbados, Venezuela, etc., came back to report. And they listed type 2 diabetes and hypertension as major concerns. But the students also told me, which I didn't believe at the time, that when they searched the library databases, there was no evidence of these specific risks of diabetes and hypertension in Black Caribbean communities. But they were right. And in fact, despite the fact that Black Caribbean immigrants make up about a third of the Black population in New York City and unspecified, but my guess is that a very large fraction of their children and grandchildren probably make up another third, that up until 2017, there was no data on the intra-ethnic differences in the Black population, as everyone was classified as African American or Black in epidemiological evidence. So my students really did an extraordinary job. And so we started exploring, and we realized this was a systemic issue that applied to most research about people of color and specifically to people of African descent. And that heterogeneity within the Black racial groups was invisible and largely undocumented. So just like a dietitian or physician has to accept the patient that arrives in their practice, a public health researcher has to take the urgent public health issue that presents itself. And quite frankly, this was not just public health, this was also a social justice issue that we had to unpack. And so that became the beginning of my dissertation research and the focus of my research lab going forward. Mm-hmm. So that's how we ended up here.
Lovely. And so help us understand, what are intra-ethnic health disparities? Do these intra-ethnic disparities manifest itself in diabetes? And if so, how exactly?
Right. So intra-ethnic health disparities means that there are people who are classified as the quote unquote same in terms of race and or ethnicity, but that within these racialized categories, there are distinct groups who are different from each other in terms of lived experiences, health status, and health risk. And so in the US, in medicine and in public health, we first divide people up by race and or ethnicity, and then we examine how these groups differ. And that's essentially the underlying issue that we're trying to uncover. And this happens because our public health data sets do not often contain an adequate sample to give us statistical power. So we can't explore these inter-ethnic variations or the heterogeneity. So generalizations essentially comes from a lack of data, and quite frankly, it's a lack of willingness to draw adequate and representative samples, because we've demonstrated with the uh, people of Latinx or Hispanic descent that because we have a large population, um, and it's well represented across the country, our national surveys actually now oversample Latinx or Hispanic descent populations, and we have evidence of distinct health differences by nationality, genetic heritage, immigration history, et cetera. And so, one thing I want to say about intra-ethnic health disparities is that there often are not negative. Minority or immigrant populations often have better health than the white or US born equivalent population. So it's not always a negative that we have to identify, but we have to identify differences within groups. Mm-hmm. And so you asked for an example. So in many cases, we see minority populations as positive outliers. For example, as much as we have written about the higher risk of diabetes or an elevated risk of diabetes, sub-Saharan African, Black African immigrants have an overall far lower type 2 diabetes risk than African Americans or Black Caribbeans, but they have a different risk profile. But in essence, we know too little about this because we have underrepresentation in our national surveys. And but in New York City, we're in this unique position to actually examine the health of more specific groups, because we're a city of immigrants and we have cultural enclaves and we have access to large groups representing the diversity and heterogeneity within the racial and ethnic groups. And that's really invaluable. And that's what we're trying to mobilize and use to sort of tell this much more granular story.
Mm-hmm. And so, building off of that, what does homogenization of African populations in healthcare research really indicate about systemic flaws in the US health system, in the food system? And then the second part of that is, why should health research really disaggregate that data on ethnicity and race? What value does it provide?
Sure. So, the way we do it right now, by assuming a homogeneity in all populations of African descent, and we do this in both public health and healthcare research and clinical guidelines, we're illustrating that systemic, structural, and institutionalized racism is pervasive. And this is particularly damaging when we list race as a risk factor, right? Because race is a proxy for lived experiences. But for instance, the American Diabetes Association just issued their new clinical guidelines, and as they've done for many years, they list race and ethnicity as one risk factor. And if people have an elevated BMI over 25 or above, and they are of African American, Latino, Native American, Asian American, or Pacific Islander descent, they are already identified as at elevated risk for type 2 diabetes. But the same is not true for other groups. But we have to remember that race is is a skin color, right? It is not actually a biological concept. It is not the skin color that puts people at risk. And so we need to get, so the reason why we should not aggregate data by race first. Race is an important concept for social reasons, for structural reasons, and for lived experience reasons. But in medical and epidemiological research, we have to be very, very careful not to aggregate by race. And that has been shown both in the regions of origin, so sub-Saharan Africa and in the Caribbean, and in the case of my research, and also in epidemiological and clinical studies in the US, is this, that, for instance, Black sub-Saharan Africans experience a higher risk of diabetes at a younger age, a lower BMI, and a lower waist circumference than we see in sort of the general US population. So in effect, by aggregating African immigrants, African Americans, and Afro-Caribbeans, we may delay detection of type 2 diabetes in some groups simply because their phenotype is not aligned with the US standard. And delayed diagnosis of diabetes can lead to irreparable damage to kidneys, eyesight, and long-term risk of cardiovascular disease. And as we've seen more recently, diabetes or increases the risk of severe COVID-19 infection and death. And so that's in part also why we've seen a higher burden of COVID-19 in minority populations and the Black populations in the US in particular.
Mm-hmm. Let's go back to the research that you mentioned, Dr. Horlyck-Romanovsky. In your research in New York City, you found that foreign-born Blacks experienced lower odds of obesity, but higher odds of diabetes than U.S.-born Blacks. How do you reconcile this increased risk of type 2 diabetes in the Black immigrant population?
Well, that's really at the crux of our work, the big why. So there are three main drivers that we are currently exploring. And we can hypothesize that recent changes in low and middle income countries where we've seen a rapid increase in body mass or body weight, that's in part the result of, as you alluded to, the food system, or what we call the global nutrition transition, the global change of food systems that leads to increased consumption of refined grains, sugar, plant oils, animal protein, and processed foods and sugar-sweetened beverages. These are essentially the changes that used to be associated with immigrating to the U.S. But now the global food environment has changed to make these food items more affordable and available, and displacing local foods and also local food habits. And so, in fact, the healthy immigrant effect, which used to be true, that immigrants arrived much healthier than the US population, that is diminishing. And then in addition to that, it's hypothesized that this increased access is also leading to rapid increase in overall fat accumulation in populations in low and middle income countries, and particularly of visceral, hepatic, and pancreatic fat that are the main drivers of the rising rates of type 2 diabetes. The other two things are there's also evidence linking diabetes phenotypes that we are seeing to transgenerational effects. So multiple generations experience translate into the health outcomes in current generations. So, for instance, the effects of famine or food insecurity in past generations can increase the risk of diabetes in subsequent generations. The same is for intrauterine exposures. So, while a woman is pregnant, the exposure, her lived experiences affect the fetus and their risk of diabetes. And then also the exposure to frequent infections in sub-Saharan Africa in particular have also been implicated in increased risk of diabetes in subsequent generations. And so that all that paired with the rapid increase in overall energy intake and fat accumulation is sort of the perfect storm contributing to increased type 2 diabetes risk. And then I just want to, the last piece is, of course, immigration experiences themselves represent unique exposures to stress. The people who get to immigrate are under extreme pressure to support themselves, support their families back home, while experiencing the transition from being part of a racial majority to becoming a racial minority. And they're facing racism and other types of prejudice, underemployment, diminished social standing, changing in food access, healthcare access, lack of social cohesion. And such stressors really increase the physiologic stress and also may increase the risk of diabetes and other chronic diseases such as hypertension.
Mm-hmm. And I think that the main thing there is also that what we know to be true as obesity being a risk factor for diabetes, it seems like there's a multitude of other things, and it's just not obesity by itself, but there are a multitude of other things that can also put it at a high risk. And like you said, I think the association that we draw today is more tied to that BMI risk for the most part.
Absolutely. Absolutely. Yes.
So African Americans have a higher risk of diabetes at lower BMI, a different waist circumference cutoff, and a younger age than African Americans. If diabetes risk assessments are not optimized to detect diabetes in African descent populations, what can be done here?
Oh, I think we have a lot of work. We have a lot of work ahead.
Yeah.
But I think we have several sort of immediate tasks. This is a more global tackling of and a sort of an anti-racist approach to many things, including the screening criteria that we use. But we really need to have this discussion on a more global level, and I mean that in the broadest terms. We have enough evidence to illustrate that there are significant issues with our current approach to race and risk. And we need more awareness among our medical professionals that race, risk, and skin color are not primary risk factors, but that people's lived experiences, family history, medical history, and social demographic circumstances are far more important. And then we really need to also recognize that many of the screening criteria that we use originate in populations that are not representative of the populations where they're being used. So we've alluded to BMI, which is a horrible measurement. Its history is a fraud. It was not used for population health or even medicine, but it's a really easy tool because it's easy to measure someone's height and weight and draw some conclusion about their level of risk. Same thing goes for waist circumference. We have different phenotypes across the globe. We cannot generalize. So I think we need to re-examine and we need to really look at the evidence that's emerging. There are several groups that are looking specifically at this intra-ethnic diversity and heterogeneity to figure out how do we actually tackle this story. But part of it is making it visible, right? So, for instance, we've had other things that have been completely invisible until we tackled them. The example this year is we're appalled in 2022 that once we see an illustration from an anatomy and physiology textbook with a Black fetus in the belly of a Black pregnant person, that somehow we have never seen that was invisible. And similarly, we need to deconstruct, uncover where these guidelines come from. For instance, hemoglobin A1C performs horribly in populations of African descent and South Asian and Middle Eastern populations because of the presence of hemoglobin variants, G6PD deficiency, and other reasons. That is really a very crude measure. And so we need to re-examine how we are, what we're using to measure, and how we're understanding the diversity of risk really in all kinds of people. So our work really contributes to this growing evidence that BMI, waist circumference, hemoglobin A1C, and other screening criteria that are developed predominantly in white populations can just not be universally applied, and that we need to deconstruct these white normative reference points. And then we really need better data to understand how else to predict risk and ensure early detection of diabetes to prevent its long-term devastating complications, regardless of what people look like. So a more holistic approach to who is at risk.
Certainly. So with that, Dr. Horlyck-Romanovsky, we are toward the end of the episode. At this point, how can our listeners connect with you and really learn more about your work?
So my email is always a good communication point. I'm also on Twitter. My Twitter handle is my first name and DRPH. So my academic title. So MARGRETHE DRPH. So that's my Twitter handle. Or my email is margrethehr@brooklyn.cuny.edu. And I really welcome open debate and conversations about how we can tackle these complicated issues.
Lovely. And what we'll do is in the show notes, we'll post all the social media handle as well as the email address there so folks can reach out to you. And so with that, Dr. Horlyck-Romanovsky, it has been an absolute pleasure having you on. Thank you so very much for your time.
Thank you so much for having me, and thank you for listening to what we had to bring to the table.
Absolutely. And to our listeners out there, we want to pose a question to you. Head over to our Facebook or Instagram and answer the following question. What will you do to not generalize individuals of African descent? Heavy question, loaded question. Head over to our social media on Facebook, on Instagram. Find us there. We're at Yumlish. And answer this question on this podcast announcement. We will see you on our social media channel after this episode. Thank you again.
Thank you for listening to the Yumlish podcast. Make sure to follow us on social media at Yumlish_ on Instagram and Twitter, and at Yumlish on Facebook and LinkedIn for tips about managing your diabetes and other chronic conditions, and to chat and connect with us about your journey and perspective. You can also visit our website, yumlish.com, for more recipes, advice, and to get involved with all of the exciting opportunities Yumlish has to offer. If you like this week's show, make sure to subscribe so you can hear more from us every time we post. Thank you again, and we'll see you next time. Remember, your health always comes first. Stay well.